Good evening, everyone. Today I'll be discussing preoperative concerns in COVID recovered patients. So, what is the relevance of discussing this topic? As this data suggests, COVID 19 has caused colossal damage by infecting almost 87 million cases worldwide. But on a positive note, almost 70% of patients have recovered. With more and more patients being considered as COVID 19 recovered, we must be prepared to treat and manage this emerging and vulnerable patient population for elective and emergency surgeries. Any surgical intervention can be categorized as immediate, urgent, and elective procedure. So, immediate procedures are life, limb, or organ saving interventions, while urgent are those which are acute onset or clinical deterioration of potentially life threatening conditions. Elective cases are those which are planned in advance to suit patient, hospital, and staff. Now, suppose a 55-year-old female patient has come for modified radical mastectomy. She is a known hypertensive controlled on medications. She was admitted in isolation ward for 7 days with COVID-19 infection 4 months back. So, what are the preoperative concerns in this case? Now, any post-COVID patient which presents to us, we want to know suitable time to operate in elective cases. What are the residual pathological concerns due to COVID in that patient? And what difference is there from the routine PAC? So, first of all, when to operate these patients? The optimal timing of procedures for patients who have recovered from COVID 19 infection is not yet clear because the post symptomatic infectious period is uncertain and the appropriate level of preoperative evaluation remains a challenge as there is current lack of evidence or precedent in this regard. Any patient who tests as RT-PCR positive can be either asymptomatic or symptomatic. So, the symptomatic patients can be again classified as mild, moderate, severe, and critical. The mild patients present with signs and symptoms of COVID 19 like fever, cough, sore throat, malaise, headache, muscle pain, but there is no shortness of breath, dyspnea, or abnormal chest imaging. Patients who have evidence of lower respiratory disease by clinical assessment or imaging and saturation is more than 94% fall into the moderate category. Severe category patients are those who have a respiratory rate of more than 30 per minute or saturation of less than 94% on room air, PaO2 by FiO2 ratio of less than 300 millimeter of mercury, or lung infiltrates involving more than 50% of lung fields. Those patients who have respiratory failure, septic shock, and multiple organ dysfunction fall into the critical category. There is one more class of severely immunocompromised patients. Patients who are currently undergoing chemotherapy for cancer or those who have received a hematopoietic stem cell or solid organ transplant within 1 year. Patients, those who are having HIV with CD4 T lymphocyte count of less than 200, or those who have a combined primary immunodeficiency disorder, or even the patients who are treated with prednisolone for more than 20 milli of with a dose of 20 milligram per day for more than 14 days fall into this category. Now, this transmission based precautions can be discontinued if the patient meets this criteria. So, the asymptomatic and not severely compromised patients, we can discontinue the isolation and transmission based precautions at least 10 days after the date of their first positive viral diagnostic test. If the patient falls into mild to moderate category but was not severely immunocompromised, then we have to wait for 10 days since the symptoms first appeared or for at least 24 hours since the last fever without use of fever reducing medications was present or the symptoms should have improved like cough and shortness of breath. Those patients who were severe to critically ill and or even if they are severely immunocompromised, we should wait for up to 20 days since the symptoms first appeared, and at least 24 hours should have passed since the last fever without the use of fever reducing medications, and symptoms should have improved. So, these patients can be assessed like any other routine patient. While the patients who do not meet these criteria can go for tele PACs, because the isolation criteria is not completely fulfilled. Tele-PACs have been widely used in COVID-19 pandemic to provide consultations. The timing of elective surgery after recovery from COVID-19 utilizes both symptom and severity based categories. Any non urgent procedures should be delayed until the patient has met criteria for discontinuing isolation and COVID-19 transmission precautions and has entered the recovery phase. There are few patients who may be symptomatic but RT-PCR negative. If it is an elective surgery, you have to delay until the resolution of symptoms. If the surgery is time sensitive type but not an emergency, like in malignancy, we can obtain pulmonary function tests to classify the residual lung pathology. Any emergency surgeries we have to take with all precautions. What are the recent guidelines? On December 8, 2020, American Society of Anesthesiologists and Anesthesia Patient Safety Foundation released a joint statement on elective surgery and anesthesia for patients after COVID-19 infection. So, as per this guideline, what is the waiting time for elective surgery? Time from the date of COVID-19 diagnosis. So, if the patient falls into asymptomatic category or have recovered from mild non-respiratory symptoms, after 4 weeks, we can take up the patient for surgery. If the patient was symptomatic like cough and dyspnea and did not require hospitalization, we have to wait for 6 weeks for surgery. Any symptomatic patient who is also a diabetic, immunocompromised, or hospitalized, it is essential to wait for 8 to 10 weeks. And if the patient was admitted to an ICU due to COVID-19 infection, then we should wait for 12 weeks for surgery. Now we can see there are some persistent symptoms in post-COVID patients. As we can see here, fatigue, dyspnea, joint pain, chest pain, these are few of the symptoms which are persisting in post-COVID patients. So this is an overview of systemic manifestations of COVID-19. As we can see here, almost all systems are affected, right from pulmonary, neurological, ocular, dermatologic, cardiovascular, GI, liver, renal, all systems are affected. But here now we are worried about the persistent symptoms of COVID-19. So our major concerns are residual pulmonary dysfunction or myocardial dysfunction, any neurological or psychiatric manifestations of the patients, lingering sequelae of arterial and venous embolic phenomenon with associated anticoagulation, or if the patient has adrenal insufficiency from corticosteroid courses. So we'll be dealing with these concerns one by one. Patient has come for PAC, so we should now system-wise evaluate and plan for preoperative optimization of these patients. Now, pulmonary system is the most commonly affected organ system with persistent respiratory complications like residual dyspnea and deranged PFTs, which signify restrictive lung diseases. And respiratory failure is commonly seen caused by acute respiratory distress syndrome in these patients. Now, literature on the myocardial effects of COVID-19 is expanding. As a part of systemic inflammatory response syndrome, a high level of cytokine surge can result in injury to cardiac myocytes. Myocardial oxygen supply and demand mismatch can occur because the metabolic demand is increased due to infection, while hypoxia may occur due to pneumonia-like symptoms of the patients. So we can see cardiac arrhythmias, heart failure, and stress cardiomyopathy commonly in these patients. Any patient who presents with hemodynamically compromised should be evaluated for residual cardiac involvement. So we have to take relevant history in these patients like dyspnea, cough, chest pain, palpitations, and syncope. Supplemental oxygen needs, pulse oximetry data should also be asked for. If the patient symptoms are persistent, worsening, or new, that may reflect the development of late complications of COVID-19, such as secondary bacterial pneumonia, empyema, pulmonary embolism, or COVID-19 related myocardial injury or inflammation. So we have to proceed with few investigations in these patients like chest X-ray, ECG, Holter, 2D echo, and PFTs may have to be performed. Chest imaging is needed only if the patient had abnormal imaging during COVID-19 illness or presents with new or worsening symptoms. HRCT is needed only if some new lung pathology is present, otherwise chest X-ray suffices. 12-lead ECG is done in almost all the patients. But in the patients who have a history or biochemical evidence of a myocardial injury or myocarditis, or any patients with dyspnea and other signs and symptoms suggesting of an underlying cardiac disorder, it is better to have a transthoracic echo. In case of transthoracic echo being unrevealing, we can go for cardiopulmonary exercise testing. Brain natriuretic peptide and troponin I can suggest heart failure and myocarditis in those patients who are complaining of dyspnea, chest pain, and edema. PFTs consisting of spirometry, lung volume, and diffusion capacity has to be done. In patients who present with persistent, progressive, or new respiratory symptoms, or also in these recovering COVID 19 patients who had severe pulmonary involvement or COVID 19 related ARDS. 6-minute walk test is also a good index of physical and respiratory function. ABGs are needed in those patients who were on non invasive ventilation during their acute illness. Now, if the symptoms remain unexplained, referrals to pulmonologist or cardiologist can also be done for further evaluation. We should also remember that few unexplained cardiopulmonary symptoms and low peripheral oxygen saturation is there despite a normal chest X-ray. Then we recommend a high index of venous thromboembolism and evaluate with an appropriate imaging exam like CT pulmonary angiography. Coming to the management, if their underlying cardiac or pulmonary disease has been identified, we can go with the pharmacotherapy for these patients. If there are mild symptoms but no oxygen requirement and no cardiac etiology, then breathing exercises can be taught to these patients like deep breathing and pursed lip breathing exercises. If the patient has moderate to severe dyspnea, that is saturation of less than 92%, and requires supplemental oxygen, then refer these patients to cardiac and pulmonary specialist. Coming to the neurological manifestation, there has been reports of ischemic stroke, intracranial hemorrhages, encephalitis, and critical illness myopathy related to prolonged intubation and immobility in these patients. So, take a complete neurological history and examination for these patients. Any degree of residual deficit should be noted to find out the impact on patient's functional status. If the patient has unexplained muscle weakness or sensory complaints, then electromyography or nerve conduction studies are needed. No neurological imaging should be done unless there is an unexplained neurological deficit or concern for a focal lesion. A meticulous review of prior CNS imaging should be undertaken for procedures that necessitate anticoagulation or thrombolytics in order to minimize the risk of intracranial hemorrhage. In case of moderate to severe cognitive impairment, neuropsychological evaluation and management should be done for these patients. Now, coming to the psychological or cognitive symptoms, COVID 19 has catastrophically affected the mental health and caused an upsurge in psychological illnesses of the patient. The strong conditioned fear and anxiety has led to emotional dysregulation and mood changes. Almost 24% of the patients have presented with post traumatic stress disorder, while 23% of patients have shown anxiety and depression. There have been problems with memory and concentration in 18% and 16% of patients post recovery from COVID. So, when the patient comes, we have to assess the anxiety and depression symptoms by directly questioning the patients or their caregiver and evaluate for anxiety and stress. In case the patient has mild to moderate anxiety and depression, he can be evaluated with a primary care clinician, but severe anxiety, depression, or PTSD needs a proper psychiatric evaluation and treatment. Endocrine manifestations. The worsening of insulin resistance in these patients leads to increased incidence of newly insulin dependent patients, increased insulin requirement in these patients, and there are few newly diagnosed with diabetes. The steroids given during the illness may cause suppression of hypothalamic pituitary axis in these patients. So, stress dose of steroids may be required in these patients. We can also suspect adrenal insufficiency if the patient presents with fatigue, myalgia, orthostasis, decreased appetite, nausea, and weight loss. If the patient has unexplained fatigue or weakness, thyroid function test should also be done. Duration of hypercoagulability in COVID 19 is unknown, but there is a high risk of arterial and venous thromboembolism. As we can see here, the hospitalized non critically ill patients have presented with 11.5% incidence of thrombosis, while ICU patients have almost 30% incidence of thrombosis. So suspect venous and arterial thrombosis if the evidence of hypercoagulability during the acute illness or in severe or critical acute illnesses. Evaluate for DVT of upper and lower extremities, pulmonary embolism, or arterial thrombosis if digital ischemia is present. For patients who are taking anticoagulants, review the duration and indication, confirm the appropriateness and safety as we do in any other patient on anticoagulation. Indications for post-discharge thromboprophylaxis are the same as in non-COVID 19 patients. If there is a history of major thromboembolic event like pulmonary embolism, then patient should be put on 3 to 6 months of anticoagulation. But if there was a minor episodes of DVT, 2 to 6 weeks of anticoagulation will suffice. Patients with new or existing risk factors like atrial fibrillation should be managed as per the recommended guidelines. In renal and hepatic, we have to assess for organ recovery with follow-up laboratory tests. As we all know that patients present with acute kidney injury or mild raised liver enzymes, so we can always do lab tests to assess the recovery. Patients with long-term kidney or liver dysfunction should be managed by specialists. Now coming to consent and pre-medication. Any patient who presents with residual symptoms or those who had ICU admission, in view of the perioperative events, it is better to go for a high risk consent. And patient and family should be informed and counseled about the present condition and the associated risks due to post-COVID 19 status of the patient, in addition to the routine risks involved. All antipsychotic agents should be continued perioperatively, and benzodiazepine should be used in severe anxiety symptoms. Now, this is our routine PSC forms which we have, but in COVID recovered patients, we will need to gather some more information from patients and available records. So in history, we should ask for the period of illness, what was the symptoms present during illness, whether the patient was in home isolation or hospital isolation, if in hospital, whether he was in isolation ward or HDU or ICU, what was the mental health status that time and presently for the patient, what oxygen therapy he was on, if he had oxygen requirement, what was the drug history he was taking, that we can take from records also because all patients might not be knowing this, what are the present symptoms and present medications of the patient, is he dependent on oxygen now also. And clinically and laboratory evaluation, as we have discussed before, as per the patient's need, we may have to do breath holding time, 6-minute walk test, ABG, chest x-ray, PFT, 2D echo, HRCT, thyroid functional test, troponin, coagulation profile, D-dimer, antinuclear antibodies and creatinine kinase in patients who complain of persistent arthralgias, myalgias, or rheumatic symptoms. Neuroimaging, electromyography, and nerve conduction studies may have to be done. So, a more thorough preoperative evaluation scheduled further in advance of surgery should be considered. Preoperative risk assessment should be individualized in these patients. Surgical intensity, patient comorbidities, and the benefit risk ratio to decide further delaying surgery. So, we have to delay surgery taking in account of these factors. These timelines which have been given are not definitive. You have to always, it will always differ from patient to patient. Mental health assessment and counseling is of paramount importance in these patients. So a comprehensive physical, cognitive, and psychological assessment should be done given the long-term sequelae. And multidisciplinary approach is needed to ensure best possible outcomes. And all anesthesiologists must be well aware of the risks involved and management of the persistent or new symptoms in COVID-19 recovered. Thank you all.